Good afternoon, Melissa. Are you able to hear us now?
Yes, I can hear you.
Wonderful. And we hear you very faintly. So if you'll do me a favor and on your end, maybe turn your speaker up.
Is that better?
That is way better. Thank you so much.
Okay.
All right. I'm going to
You
turn
are
the mic
welcome.
over to Marcia. Good afternoon, everybody. Thank you for your patience as we work through technical difficulties. Always a funness with these new hybrid meetings. This is our first hybrid best practice conference. We appreciate your patience. I'm going to turn it over to Dietrich, who's actually the moderator and knows more about what to say than I do. So here's the mic.
You did a good job saying a lot of stuff. So great. Thank you. Thank you, Angela, and thank you, John. So I'm going to turn it over to Marcia. She's going to introduce Melissa, and we're going to get started with Dsmt and the billing process. Thank you all for attending and look forward to a great presentation.
All right. Good morning, everybody. As Dietrich said, I am Marcia Carlson with Encompass Health Solutions, Vice President of Revenue Integrity and Growth. And so I just want to give you a short background of who we are at Encompass. Encompass partnered with USET back in 2018 on a revenue cycle optimization program. And that came about because USET had reviewed a GAO report that said that tribal clinics were leaving millions and millions of dollars on the table in third-party revenue just simply because there wasn't the training or they just were not able to collect that money. And so we came to the table with some expertise in the revenue cycle, and USET wanted to be able to provide that resource to their member tribes. And so that is our passion, really, is to provide that hands-on training and support so that those clinics can collect as much third-party revenue as possible. The goal being able to be self-sustaining, as well as to get to the point where it can even increase services to your patients, or increase your staffing, or maybe get new equipment, whatever the case may be, but just trying to increase that third-party revenue for the clinics. So due to the unique complexities of tribal healthcare revenue cycle, we have been fortunate to be able to add to our team people who have that experience specific to tribal healthcare revenue cycle. Before we start the presentation, just out of curiosity, looking at our group here, and I know we have virtual attendees as well, but what is your role? How many of you actually provide this Dsmt training or do any coding or billing related to it? For those of you in the room. Yes. Okay. Okay, great, great. And I happen to know Mary. Mary, I know, provides the training. Anyone else want to share? You don't have to if you're not comfortable, that's fine. Okay. Perfect. All right, sounds good. All right. Well, we'll go ahead and get started. You may have noticed a different name on your agenda if you were looking closely at that. Wanda Prada from our team was going to present this. She unfortunately was unable to make it today, but I'm really excited to introduce Melissa Schroyer from our team. And Melissa has 6 years of coding, auditing, and training experience, all specific to Indian Health Service or tribal health clinics. So Melissa has been with Encompass since 2019 and really truly is a key member of our team. So Melissa, with that, I'll let you take it from there and do the presentation.
Thank you, Marcia. All right, good morning, everyone. So as Marcia said, we are going to do a review on the diabetes self-management training for documentation, coding, and billing best practices. If I start to move too fast or talk too fast, just let me know. I can do that sometimes. All right, so let's dive right in for the general information. So the diabetes self-management training is an interactive and collaborative process, involves both the person with the diabetes as well as the diabetes educator. The process includes assessment of the individual's specific education needs, identification of the individual's specific diabetes self-management goals, education and behavioral intervention directed toward helping the individual achieve their goals, and evaluation of the individual's progress towards their self-management goals. For providers intending to bill for the diabetes self-management training services, a copy of a CMS-approved national accreditation certificate is required. CMS recognizes the American Diabetes Association and the American Association of Diabetes Educators as approved national accreditation organizations. DSMT is also known as DSME, or Diabetes Self-Management Education. Although DSME is the preferred term, CMS requires the use of DSMT in the reimbursement documentation. Section 4105 of the Balanced Budget Act of 1997 permits Medicare coverage of outpatient DSMT services when these services are furnished by a certified provider who meets certain quality standards, which is effective July 1st, 1998. The benefit is available for beneficiaries with diabetes or renal disease when the referral is made by a physician as defined in 861RI of the Social Security Act. It also, also allows registered dietitians and nutrition professionals to receive direct Medicare reimbursement for the first time. The referring provider must be enrolled as a Medicare Part B provider, and once the diabetes education program recognition is received, a copy of the ADA or AADE certificate must be submitted to Medicare. All right, now coverage limitations that apply to DSMT. So a written referral from the beneficiary's treating diabetes provider, which could be a physician or a qualified non-physician practitioner, such as a nurse practitioner, who is medically managing the beneficiary's diabetes, is required. The order or referral must include the diagnosis or condition, a written comprehensive plan of care, the number of initial or follow-up hours ordered, topics to be covered in training, and the signature of the referring provider. And no payment will be made for group sessions unattended, which is tracked by the class attendance sheets. CMS considers DSMT and MNT, which is the medical nutrition therapy, as complementary services. This means Medicare will cover both DSMT and MNT without decreasing either benefit as long as the referring physician determines that both are medically necessary. Although DSMT and MNT are considered complementary services, these cannot be billed on the same date. Also, Medicare does not reimburse FQHC for the group DSMT services, which would be under CPT G0109. And DSMT will not be reimbursed on the same day as another FQHC medical appointment, such as a primary care encounter, except a mental health visit. All right, the DSMT coverage limitations. For the initial, this is considered a once-in-a-lifetime Medicare benefit. It is important to verify that the beneficiary has not received any initial DSMT covered by Medicare. If the beneficiary has received initial DSMT paid by another health insurance company, they are still eligible to receive the 10 hours of initial DSMT as a Medicare benefit. 1 hour of individual DSMT is payable in the initial episode of care, but the remaining 9 hours must be furnished as a group services unless one of 3 specific conditions are met, which allows all 10 hours to be furnished individually. And these specific conditions would be that there is no DSMT group class available for 2 months or longer from the date on the referral. The referring provider indicates on the referral that the beneficiary has 1 or more barriers to group learning, which could be reduced vision, reduced hearing, reduced cognition, any language barrier, or if it's non-ambulatory. And third, the referring provider indicates on the referral that the beneficiary needs additional insulin training. And then an important note here, if more than 10 hours of DSMT is billed in the first 12 consecutive months, the claim will be rejected by Medicare. If the beneficiary does not receive the entire 10 hours in the first 12 consecutive months, the balance of that 10 hours would be forfeited. And then for the follow-up on DSMT care, 2 hours are allowed for DSMT follow-up in specific time frames following the initial intervention. And then hours on that can be spread over any number of visits during the year. So one visit equals 15 minutes. So it could be multiple 15-minute visits to equal up to 2 hours. It could be a half-hour visit plus some 15-minute visits, as long as it adds up to just those 2 hours within 15-minute intervals. And then a referral for the follow-up DSMT is also required. Qualifying diagnoses that would make the DSMT medically necessary: diabetes, and it can be type 1, type 2, or gestational diabetes. Then we have kind of a brief definition of what would meet the requirement of diabetes being a diagnosis. For the blood sugars, the 2-hour post-glucose challenge, as well as a random glucose test over those requirements. And then also a renal, so the kidney, which must be reported as a secondary diagnosis to diabetes. So also non-dialysis kidney disease, as well as post-kidney transplants qualify under renal. Okay, so these are the CPP codes that we would use to report the DSMT. The G0108 is your diabetes outpatient self-management training services individual for 30 minutes. The G0109, the diabetes outpatient self-management training services group session 2 or more per 30 minutes. And then just a reminder that Medicare does not reimburse the FQHC for group DSMT services. And then FQHCs must use G codes when submitting claims to Medicare under the FQHC prospective payment system. G0466, FQHC visit new patient. And then G0467, FQHC visit established patient. All right, then we go into the documentation requirements. So these are the best practices to facilitate timely and accurate coding and billing. All these things will need to be included. We need the patient name and medical record number, the accurate date of service, qualifying medical diagnosis indicating the condition that requires training, written provider referral and signed statement of need on the initial encounter, the date of original referral on all subsequent visits, the topics discussed, goals discussed by and agreed on by both the patient and the provider, follow-up visits, the rendering provider signature, the referring provider signature, time in, time out, or the total time, so we can calculate the number of units, individual or group encounter, visit number with the cumulative time spent with patient to date, and then the DSMT G codes appropriate for the service that was rendered on that data service. So looking at this would be the components of kind of what a DSMT chart would look like. So we start with 1, which would be the initial assessment. 2, the individualized education plan. 3, the SMART goals and goal achievement. 4, education provided, the curriculum content that's being provided to the patient. 5, the ongoing support plan. And 6, the communication back to the referring provider on the progress and such with the patient. All right, and then another area we're going to look into is the top documentation errors to avoid in applying for DSMT reimbursement. The first one is the facility does not have a current certificate showing accreditation of a DSMT program. The patient does not meet medical conditions for DSMT, meaning they don't carry a diagnosis of diabetes or kidney disease per the Medicare criteria. There's no order or plan of care from a physician or qualified non-physician practitioner for DSMT, or there's not enough information in the order. The order must include the patient's medical condition requiring DSMT, the number of initial or follow-up hours the patient needs, topics to be covered, patient's condition that requires individual training instead of in a group setting, and the order must be signed by the ordering provider. Our documentation does not show medical need for individual training instead of group. DSMT guidelines state that the patient can have 1 hour of individual training, but the remainder should be provided in a group setting. And again, the exceptions for the individual training is that there's no group session available within 2 months of the date the training is ordered, or the patient's treating provider documents that the patient has special needs resulting from conditions such as vision loss, hearing loss, language limitations, or other such special conditions that would hinder effective participation in a group training, or the provider orders additional insulin training. This must be documented, and if individual training only is required, it must be on the order. Follow-up training must be documented with an updated order from the provider, and medical records do not show the time spent and coverage in the training session. That would be the completion of the training. I don't know if anyone has any questions on anything in there.
Okay, any questions here in the room today or virtually? I don't know how to check that.
I'm gonna ask this.
Okay.
Based on like the work with clinics. I know you don't work with some of the tribal nations have. So what is the process for them connecting with you, your organization, to say do something? Meaning, so say they have their own billing department, but they wanted to connect with you to do the diabetes education or the DSMT, Csmt. Is that a possibility?
Yes, for sure. That would be something that we could do for them. So that would be a matter of just contacting me, and we would set up a call to go through any specifics with you and how that might work, go through all the details that would be relevant specific to your tribe. And I am certain that we could definitely be happy to work out, you know, a time where we could either come on site or just over the phone, develop a process for helping you get that set up and moving it forward. Right. That's what I understood Dietrich was asking. Yes, we would do, that by itself or, more involved if needed or wanted, but certainly speaking just to the diabetes, we could certainly do that.
And so the other thing that we talked yesterday in the session when we talked about ADCS. So either in order to deal with diabetes, there used to be 3 organizations you could go. IHS, it was AADE, which is now ADCS, and there was also ADA, which is American Diabetes Association. Now, as I understand it, it's either you have to be accredited or recognized through ADA or ADCS. And we will help you through that process. We mentioned that yesterday. So we mentioned to the combination there today that, that we'll help them with the accreditation process. We'll also help them to one of the certified diabetes educators, that, will help them as well through that process and techniques. But once they are heard, once they are recognized, then they can deal with diabetes education. For the tribal nations, and I like to talk about the FQHCs and adding an extra code. We were talking a few minutes ago about the group classes versus the individual classes. Could you just expound a little bit or clarify for me if they are recognized and they go through the process, right? Can they, with Medicare, can they do group classes or does those classes have to be individual? For the Medicare specifically.
Melissa, did you hear that? Can you take that?
I can only hear bits and pieces.
Did you say you didn't hear it?
No, I could only hear bits and pieces of it.
Dietrich, let me give you the
I
mic.
can hear you, but okay.
Perfect.
All right, thanks, Melissa. I'm sorry, can you hear me now?
Yes, I can.
All right, so the question is for Medicare, when they're using that G0108 code, for FQHCs, can they build the G0109 code? If they were doing a group class with Medicare patients, can they build that, or can they only do the G0108?
So, and that's kind of, yeah, because so for Medicare, for the FQHC, they're not going to cover the G0109 on there. So you would use the G0108 for the initial, the first hour of individual training.
Mhm.
And then they're not going to cover the G0109 on the group.
Right.
That is a very good question, and I would have to look more into detail on why CMS decided not to cover that. That's a very good question, though.
So, but the good part about it is like I was explaining to them yesterday. So that client who's sitting in the dental, waiting for a dental visit or waiting for a behavioral health visit, you could pull that client, which is a Medicare client, into diabetes education, because a lot of times, like, we waited too long. Well, this is an opportunity to work with your dental clinic to say, hey, listen, if you're backed up and your hygienist and your dentist are not, are backed up and you have clients and we need to see them, that may be an opportunity right there, because you can bill a behavioral health visit and a DSME visit on the same day and a dental visit and a DSMT visit on the same day. For Medicare, yeah, for Medicare, you can't be. Actually, you can do it for 30 minutes. You can do. No. Okay. I don't want to answer that question, but I'm gonna answer. So, like, say for instance, or because I like, so if Dietrich Taylor walked in there today and he's never had diabetes education before, he has 1 year from today being the 10th to next year to use those 10 hours of diabetes education. Right. He has 10 hours. Now, that's anybody. That's whether you are not a tribal citizen or a tribal citizen. If I just had a clinic outside in Hattiesburg, Mississippi, they will cover for the first time you've ever received it. And what we ran into, and the reason why we did is because, like, when I was at the health department in Mississippi, we got the health department recognized as a provider of diabetes education. And what we found is people had diabetes for 20s and 30 years, but they never had diabetes education. So that if you were diagnosed with diabetes in 1980 and you never used your 10 hours, when you walked in a clinic in 2010 and you never used it, those 10 hours, they were available. You see what I'm saying? So that if I start using them today, I have from now to next year to use those 10 hours. And then after that, you get 2 hours for the rest of your life. Yeah. Chris, don't ask me no hard question. Count up. That's what Melissa's here for.
do 1 hour of individual Dsmt and the other 9 hours must be free. Right?
So that's outside of the same. So
That would be reimbursed for the individual.
Listen, am I right? Don't get me wrong. See, I'm working on it, and as far as I know,
Melissa, did you hear that?
No, I can really only hear whoever has the mic.
The microphone. Okay, so we'll try to be better
Yeah.
about that, but
Okay.
Dietrich said so they could get 10 hours of individual because Medicare will not reimburse the FQHC for the group. So they could do the 10 hours all as individual. Is that accurate?
You know, that is a very good question, and I want to say yes from what I know of it, but I would probably want to double check and just make sure before we give everyone the go ahead to do that. But that's definitely something we could do some more research on and just to verify and then get back to everyone.
I'm only saying that because of what I've seen.
Mhm. Right. So I think what we can do is we'll provide a follow-up to that. We'll just do a double check on the Medicare guidelines for the FQHCs for the individual and group, and we will send that out, or we'll at least send it to Dietrich and he can forward it on. Correct. Non-FQHC would not, yes. Okay. Pass it back to him.
Yeah, but the other part of that is what you're gonna find out is that, like I said, you had these clients that have had diabetes for years and years and years and years, and they, right, but right, you're absolutely right. They've never billed those codes, so those 10 hours are still available for a lot of them. So yes, M&T has nothing to do with, yeah, it's separate with the accreditation process. But the difference in M&T is that you have to have a doctor's order. So like a nurse practitioner who's caring for the client, like Melissa was saying, she's absolutely right, can, yeah, right, the DSMT, but for M&T, it has to come from an MD or a DO who's caring for that same client. Yeah, and the increments are different. I think it's 15 for MNT and 30 minutes for the SMT. Yeah.
And y'all bill all different types of insurance. It's not just like the private. Right. Yeah, exactly.
Marcia, I want to see you. No, please.
I got another question about the order. You know,
Do you mind using them?
This is really simple, but I got to figure this out. Right now we use consults in our EHR, and I believe that most of that required information is in there, but I'm going to have to go back and look. Will that suffice as an order? Like we don't have to reinvent the wheel and make a paper order with all those things. If it's covered in our consult that's in our EHR, that will work.
Yes, and I have seen clinics using that same, you know, as long as it has all the information you need and it's documented in the EHR and it's clear where it's documented in the EHR, it should suffice and meet those requirements. And
Okay.
I have seen people that use that consults
Yes.
for the same
Okay.
purpose. So
I was going to say the same thing.
Thank you so much.
you're welcome.
For ADA and ADCS as a, oh, please no. I used to work for them as an auditor, like part-time. They would send me to these places to do those. And in that case, just like Melissa said, is I would ask you to show it to me on the screen and or print it out and de-identify it. Because that console, a lot of times you can print them out of the system. You just print it out, de-identify it to show me that It came from a doctor to your department and you're good to go.
And then I do my note, I sign it, it's attached back to what they do, so it all goes together.
It all goes together. And working with ADCES, and I keep saying, I want to say AADE and ADA. They want your program to be open. And that's one thing that came out of our session yesterday. This is a service that's so needed, and because it brings in revenue to the program, but it gets that education to the client so that they can better manage and treat their diabetes. And then the other piece of that is that having an organization like Encompass on the left side of it that's basically handling all your business, the business of billing needs, you know what I'm saying? And taking that pressure off the program gives you more opportunity to see your clients, get those referrals and do those things so that you actually can, see more clients. Because the more clients we educate, the better diabetes is going to be. There's too many people walking around with diabetes and really don't understand the intricacies of, how to take care of it and how to manage it. So, yeah, I'm glad to be working with you. I'm glad this thing came in. Yeah. All right. So there you go. Please take it.
Yes, sir. But you'll just ask for it in another second, but I'll be prepared. Okay. All right. Not sure where we're at with time. We're getting close here. So any other questions before we wrap it up? And Dietrich, I don't know if there are any virtual questions. I don't know if we have access to them. Okay, sure. No, that's why we're here, right? It's a perfect time to ask questions.
As far as like if we do decide to do this, is this something that's provided by USET, or is there another, like, what's the cost? Like how much?
Great question. Great question.
How much do y'all charge to help us?
Show me what.
About that.
Okay. Okay.
Yeah.
Money
potentially
bill.
for This, we might do it something a little bit different. It might be like a flat monthly fee or something like that, or a per claim.
Cause I'm gonna have to like get a procurement and all that stuff. So.
Take some time.
Okay.
I know.
I got you.
But yeah, we can talk more about that and get that figured out for sure. Yes, we would be happy to. USET should already have a copy, so certainly that can be distributed. We'd be happy to share that. We partly did the way we did with so much detail so that it could be used as a reference guide. So definitely happy to share it. Right.
Okay, well, if there's no more questions in the room, let's give Marsha and Melissa a great round of applause. Thank you all so much for presenting. This is valuable information. It's valuable. And Marsha and I was talking about a month or so ago. We've talked about this on and off, but when you are, visiting, I'm doing site visits at the tribal nations, you see the need for this type of service and this type of collaboration. So as far as, becoming a recognized program, the stuff that we started yesterday, so that you can bill for it, and then working with Encompass so to understand the billing process and, potentially the opportunity to work with them to help lessen that load of that side so that we can see more clients and affect positive change in the people that we serve is huge. Sure.
You're doing. But no, just one quick thing. I also just wanted to say, like, even if you're not at a point where you wanted to outsource that part of the billing or something like that, we're even available just for questions. I mean, you don't have to sign up for a whole program or whatever. We would be happy to just answer some questions or set up a call to help talk you through it too. So just wanted to throw that out there.
All right. Thank you all for attending. Let's give them another round of applause. I also want to thank Erica Charlie, who's handling things behind the scene virtually for us today. It's a great session, great information, and continue to enjoy Best Practice Conference with USET. Thank you. We do have a presenter's gift for, we're going to figure it out. We have one for both of y'all, and we'll go from there. Thank you all so much for attending.